a little bit about needs assessments. And as he said, when the list of desired topics was circulated around, this was on it. And I haven't, given a primary lecture about needs assessment before, and as I began to look into it, it was obvious that it is such an immense, broad, varied topic that I sort of began to hone it down a little bit, and I sort of wound up making more like a hybrid talk about needs assessment in general, and then to focus a little bit more concretely on the work we're doing at CHOP involving video recording during resuscitation and how that's serving as a needs assessment for us in terms of, critical procedures in the ED. So what hopefully I'll do is just review a little bit about definitions and general considerations when it comes to needs assessments. And then I'll probably spend the most substantial portion of the talk talking about the various methods of needs assessments. And I will try to talk a little bit about the pros and cons of each method. And I want to try to contextualize them all by using the examples of intubation and CPR as sort of, bread and butter resuscitative procedures that, I know most of us are acute care providers in some setting or other, but that, are ubiquitous, but have, come under scrutiny in recent years as being problematic because they're not, common enough that all of us are as comfortable as perhaps we ought to be. So I started by going to, I don't know, Wikipedia or something, and looked up needs assessment, and I found the needsassessment.org website, which was actually good because it crystallized the simplest way to define some of these things. And the definition they give is that a needs assessment is a systematic process of asking questions, comparing answers, and making decisions about what to do to improve human or organizational performance. And this concept is certainly not unique to medicine. It is, it's meant to be applicable to pretty much any model of an organization, whether it's business or medicine or finance or anything along those lines. They set out a series of features that a well-conducted needs assessment should include, including that it should be systematic, meaning not narrow. It should be broad enough that you're encompassing all of the facets of what may or may not be important. Hopefully each of these will be illustrated a bit by the examples I'm going to give from the literature in a couple of minutes. Justified, that's kind of an easy one, that the changes that you're setting out to make or the shortcomings you're setting out to address need to be of importance to the organization. Scalable, meaning that there is something that's measurable and has some quantitative aspect that you can demonstrate. Replicable, which is self-explanatory, and then interdisciplinary, which for us I think is particularly important because it's really easy to get our captive audiences, whether it's residents or fellows and so on. But those of us who have done simulation-based assessments using, homogeneous populations are well aware of how limited that can be. And the same goes for this when you're in sort of a native environment and trying to honestly determine what you're assessing. So there was a recent article from Matola et al. And from Barry Issenberg as well in Medical Teacher that was a big comprehensive summary of how to incorporate simulation in, or I should say not incorporate, but how to, the various ways that simulation can be used in education. It was very, very thorough and sort of an up-to-date review. And what I did with that paper was to simply look for the phrase needs assessment throughout that paper, and it only appeared twice. And it was once in the section that said curriculum integration, saying that determining how to best integrate simulation is facilitated when an existing curriculum has a defined map or objectives, meaning, if you have a learning curriculum that you want to enhance with simulation, that to begin with a needs assessment is one method to sort of determine the best manner in which to deploy the simulation milieu in that curriculum. And then another one they mentioned was capturing clinical variation. So to choose a simulator with necessary characteristics can be challenging, and then a careful needs assessment and focus on the most important clinical cases to be encountered is a means by which you can target how which simulator and how to do it and so on. what was interesting is when you think about the needs assessment and all of the possible ways it can be done and all of the things you might want to assess, I was a little bit surprised that this article didn't have more to talk about, except that it's such a broad topic that it's hard to dedicate a fragment of an article to it when it's so vast in and of itself. And then, of course, we're quite sure used to things like what we're going to assess. So obviously our let's see if this animation works. Katie, is there a way to click through the animation on this slide? I'm clicking on the bar on the side, and there we go. Okay, good. So obviously we're assessing performance as a global construct, and Katie, if you're clicking, you just kind of go through one oval at a time. Yeah, there you go. So we're talking about individual performance or team performance, and among the individuals and teams, are we talking? You can keep going, Katie. I'll just kind of talk quickly. Is it nursing? Is it physicians? Is it other people? Is it clinical performance? And if so, do we mean cognitive clinical performance, behavioral performance, or some other aspect of crisis resource management related to communication or teamwork or something like that? Is it psychomotor skill performance, acquisition, maintenance performance thereof? And then among those things, is there the quality of the task that's being performed, the timing of the task that's being performed, the sequence of the tasks? These are all sort of legitimate constructs, and that was meant to be sort of a Venn diagram. It's not really. It's not even close. But what I was trying to illustrate is that when you begin to do this, it's important on the one hand to be broad and systematic, but on the other hand, it's easy to or not easy, I guess actually more correctly, it's difficult to think ahead of time about all of the facets of the things that you're going to be assessing. And I think going in with an open mind that you're going to be able to predict some of what you think you need and want, but a lot of this is going to be a discovery process that you'll learn and probably be surprised by some of the things that you see that you need to fix or address. And then the next slide is a blank slide, and then Katie, if we can have the first video clip. This is about a 1-minute video of a scripted performance from our ED with some of our fellows that I wanted everyone to watch. And I'm hoping that as you watch this, you can just kind of think about, were you running a simulation with trainees and this was what you saw? What are the needs that are coming up, and what would you have been looking for, and are there things that you saw that surprised you?
All right, so you're working in the emergency department, and they bring in a 7-year-old boy that's been feeling palpitations this morning. He's just been put in a room. They stepped out briefly, but they called you back when he lost consciousness. Okay, so go ahead.
All right, so Kyle, why don't you do our primary airway?
He's not responding or talking to me.
Okay. Do you hear breath sounds?
I don't hear breath sounds.
Okay, so let's start positive pressure ventilation. And Robbie, if you could hook him up to the monitor, that would be great.
We do have chest rise with bagging.
Okay.
It's on the monitor.
And your rhythm is V-fib.
Okay, so we have V-fib. So can we please have the defibrillator, and let's give him 2 joules per kilo. So let's shock him with 50.
We'll hopefully in the discussion part we can reflect a little bit on what you saw and what you didn't see, and we can talk more about cases like that. All right, so when you're thinking about if you're going to do a needs assessment, or if you want to sort of gather information to be used in curriculum generation, what are the methods that can be used? And this is not a very complete list, but it's a handful of methods for which there are examples in the literature that we can talk about. Obviously, surveys and questionnaires are common and relatively simple. That's probably the one that's best represented in published studies. Medical record review, using simulation itself as a needs assessment, which is one that I know some of us have had some experience with. Using device feedback, meaning some sort of technological implement that can be used during clinical care that gives objective information about performance. And then lastly, video recording, which is a kind of segue into that as the work in progress part at the end of the talk. And as I said, what I'm going to try to do, just for the sake of context, is talk about examples that are pertinent to intubation and CPR in pediatrics. So starting with surveys and questionnaires. So pros and cons of this. The pros are obviously that they're simple, they're inexpensive, they can be directed to specific groups, you know, based on their background, and it's easy to tailor the content and the distribution to exactly who you want to get responses from. The cons of a survey are that the response rate is typically, you know, less than you hoped for and less than you expected. The question design can be tricky. You know, there's a whole science of, you know, question design and how you actually gain information like this. The data quality may be subject to bias because it's coming directly from people that have their own opinions and their own backgrounds. So a couple of examples in recent literature in pediatric resuscitation of surveys and using them as needs assessment. One that was that came out in Peds Emergency Care a few years ago from Joe Losick was a survey of emergency medicine program directors, where he and his co-investigators created a survey of 20 questions, 4 that were yes and no, and 16 that were multiple choice, looking at tracheal intubation practice in the pediatric emergency department. And these were large-scale questions about how often it was done, who did it, what personnel were available, what devices, techniques, etc. were in use, and so on. And the findings, I think, were somewhat interesting. This is a table showing the number of estimated versus actual reported intubations. And when you look to the left, the census part is the you know, annual visits to the ED in question. So you see that they were larger as you go down that column. And the red shows the actual recorded number of tracheal intubations among the programs that were able to report them. And you see that even in the busiest EDs, the ones that were up to and above 40,000 patients per year, intubations per year were only happening at a rate of about 60 or 60 per year. So, you know, we're talking about 1 a week, 1.5 per week. It's relatively infrequent, certainly at the level of the individual provider. It's not a very common occurrence. And what was interesting is interpreting that data by the respective program directors. He asked pointedly whether the person filling out the survey believed that there were adequate opportunities for the faculty to retain their competency in intubation based on their experience. And the median number of intubations per physician was reported at about 5.7. And there were 62% of the directors that said that the opportunities to retain competency were inadequate. But when he stratified the responses by whether they said, whether the director that answered the survey said that experience was inadequate compared to adequate, you see in the box below that among the EDs where the director said, no, we don't get enough experience, the median was 5.4 per position. The directors that said, yes, our experience is perfectly adequate, it was 6.8. And there was no, you know, so statistically it was a small number of programs. There was no difference between those two numbers. But I think it's interesting that with such a narrow difference between what's adequate and what's inadequate, this, I think, is illustrative of the varied perspective that program directors would have. And so as you're going into this as a needs assessment, what do you do with this information when you're faced with inconsistent beliefs from the people that you're going to be learning from? We had a recently published study from our simulation lab looking at intubation performance using video laryngoscopy among emergency medicine physicians. As a part of that study, we asked sort of some background data just to sort of control for intubation experience. And you see in the rightmost column there, among pediatric emergency medicine attendings and pediatric emergency medicine fellows, we asked them how much time had gone by since their most recent intubation in age categories, newborn, infant, and adults. But in the rightmost category, you see where it says any age patients, the average time since the last intubation of any pediatric patient for an attending was 15 months, and for fellows it was 6 months. So again, this is even less experience than the Losick study would suggest. And what about examples for CPR? Again, this is an infrequent occurrence in the ED. We published a study looking at the use of simulation in PALS training with pediatric residents a few years ago. And as part of a background for this study, we asked for, again, these were PGY1s and PGY2s at 3 Philadelphia area centers. And we asked them some background on basic procedures, that they had a chance to attempt and been successful at. And among these junior residents, the median number of times that they had performed CPR was 0, and the maximal number that anyone reported was doing it 3 times in their first year and a half of residency. Defibrillation was interesting. We had 51 residents from 3 programs. Not one of them had ever used a defibrillator on a patient. And this is not very far different from the data that Betsy Hunt got in her survey at Hopkins when she looked at resuscitation experience of pediatric residents, and these were senior residents who were further along in their training. And Katie, can you just click the animation on this slide for me? There we go. So she found that during pediatric residency, the number of cardiac arrests that had been attended by a given resident was a median of 4.5 with a range of 0 up to 20. And then the number of residents that had actually performed defibrillation during a cardiopulmonary arrest was 5%, only 4 people out of 76 respondents. So again, these are, thought of as bread and butter techniques, but these surveys, sort of range of needs assessments would demonstrate that they are not happening very often for pediatric residents. Okay, so what about medical record review? This is, another technique that is simple, inexpensive. It has the theoretical advantage that it reflects data from actual patient care, and the disadvantages are that it can be time-consuming. It becomes, it takes on the issues of confidentiality and, IRB oversight and so on. The data on opportunities for improvement may be elusive, by which I mean, depending on what it is you're assessing, it may or may not be apparent from charts, the details or the nuances that you want to intervene on. So a recent example from Cincinnati from Matt Midiga and his group there looked at procedure data from resuscitation records in their ED, and they were looking at several different types of procedures, but I'm just presenting what they found about intubation. So in reviewing a year's worth of resuscitation records in the Cincinnati ED, they found that among faculty, which is the top set of bars, the median number of intubations performed by a pediatric ED attending was 0. And only 37% of their faculty actually did it at least once in a given year. And below that, among their fellows, the median number performed per year was 2.5, and the range was 0 to 9, which means that among their 12 fellows, there was one of them that went through that entire year and never intubated a patient. And none of this is meant to be judgmental or problematic. These are large, busy tertiary centers. It's just a reflection of the fact that it doesn't happen very often. All right, so what about using simulation as a means of needs assessment? So the advantages here are that it can be, it can be sort of tailored and instrumented to target specific questions. You can direct it to specific potential learner groups and make it contextually appropriate for whomever it is you want to assess. The disadvantage is pretty much the usual disadvantages that get cited from simulation in terms of expense and space and time. And then one of the bigger, more problematic disadvantages of this is how accurately does someone's performance in a simulated setting reflect real performance, which is just one of the ubiquitous underpinnings of using simulation for this sort of thing. So one of the great examples was from Frank Overly and Stephanie Sudakoff, where at Brown they took pediatric residents and put them through simulated cases of respiratory failure, and it was meant to be an assessment of intubation performance. They defined a priori a set of critical actions that they wanted to assess how well and how frequently they were done. And then in sort of an open way, they looked to see what harmful actions were recorded. And these weren't determined. They just, as they were looking, they were going to keep track of things that were done that they thought could have been deleterious in a real situation. And I think their findings are very interesting. This is a really good example of having to go into a needs assessment with your sort of eyes and mind open, because on the left you see that intubation was successful 56% of the time. Other common metrics of success like appropriate medications was 66%, end-tidal CO2 was 34%, and those were the outcomes that they set out to document. On the right are the harmful actions, and when you read this list, I really doubt that Frank or Stephanie anticipated some of these, like someone was going to put the laryngoscope blade on backwards, and not just one person, 2 people did that. And it's sort of like when you have to really kind of be broad, and you never know what you're going to see. I think I doubt very much that when they set out to do this needs assessment, they listed, okay, we're going to see who assembles the equipment wrong. It's just a good example of having to, and not presuppose anything. This was just a follow-up study that they published in PEC, where they took these residents and put them through a crossover intervention design. And you see in the table there that between baseline and the follow-up sessions, that their critical outcomes, even the ones that don't necessarily depend on the simulated milieu, like end-tidal CO2, all improved with their intervention. I listed this, not that this is part of the needs assessment, but this is a good example of the culmination of the needs assessment, where you take that, design a curriculum, and have scalable, replicable outcomes that you assess. All right, and then this is some data from Betsy Hunt's very heavily cited paper about the first 5 minutes of resuscitation. These were unannounced mock codes at Johns Hopkins that residents were asked to, required to come and perform at, and they would, among the ones that involved cardiopulmonary arrest, she measured a lot of different metrics of success. This is just one table from that, or one figure from that article, showing the number of minutes elapsed from the onset of pulseless arrest to the initiation of chest compressions. And you see that it took up to 2 minutes for almost 2/3 of the participants. And then some of them took very long. There were some outliers at 13 minutes, but for more than 5 minutes to elapse happened in a substantial subset of this learner group. A more recent study that I think was very interesting came out of Birmingham, Alabama, from Nancy Toffel's group. This was, again, unannounced mock codes that were run with multidisciplinary teams of residents, nurses, and respiratory therapists. They ran cardiac arrest scenarios with a specific eye looking at ventilation and trying to see how ventilation was performed during simulated CPR, and to see if there was any difference in how it was performed based on what person actually did the positive pressure ventilation. And this wasn't scripted, just the team would respond, and whomever did the ventilation was just who did it based on the dynamics of the team at the time. And knowing that the PALS guidelines would recommend a rate of no more than 20 breaths per minute, it was found, as has been documented elsewhere, that hyperventilation was not only pretty much ubiquitous, but it also didn't vary depending on who was doing it. So if a doc, a nurse, or an RT was doing it, everybody was ventilating too fast. So again, you might think going into this that there might be some groups that are less prone to this. This would suggest otherwise, that everybody could benefit from an intervention, a training intervention that minimizes this. I'll go quickly through this one, the direct measurement during clinical care, by which I mean device feedback. So this is a much more narrow, uncommon one. There's not very many devices out there that facilitate this. I'm going to talk specifically about CPR quality devices briefly. The advantage of this is that you can precisely measure actual performance. The data is very high resolution. The con, obviously, is that there's cost. There's simply not that many devices out there that do this. Another interesting con is that they are difficult to implement. If you can imagine having to remember when a child is arrested in your ED, not only to do everything right, but for someone to go get the device for you, that's tricky. That's a sort of mindset that takes time to kind of permeate in a care community. This is just a quick slide to remind everyone of the current recommendations as far as CPR parameters, rate, depth, and most of us are probably very familiar with this. I don't need to go into it very much. This study, and Katie, if you could just do the animation for this, this was probably the one of the most important studies that got factored into the 2005 AHA guidelines. Ben Abella, who is an adult emergency medicine physician who was at Chicago during this study but is now at Penn next door to us, documented with a device that at the time was a prototype but now is sort of out and in use, looking at adult cardiac arrests in the hospital, found that as you look at the red boxes, slow and shallow compressions were actually quite prevalent, and that hyperventilation was very common. At the bottom, there's a row for NFF, or no flow fraction, meaning the period of time during an arrest that chest compressions are not in progress. And they have a goal towards that being less than 20%, and they found that 40% of segments had chest compressions not in progress more than 20% of the time. This is the Philips MRX. It's one of a number of devices that are out there that are physically placed on a patient that are used to give feedback during CPR. And I'm trying to get my, so here's a pointer. If you look right here, this is sort of a a waveform that corresponds to compressions. Each downward deflection is one chest compression. And these lines at the bottom are a zone calibrated to the appropriate depth of compression. So this enables people to actually do CPR and get real-time feedback when it's in use. This little thing right here that we have come to call the hockey puck, or the puck for short, is placed on the sternum and the hands go over it while CPR is in progress. And this is what the output from that that device looks like. If you look at the column or the rows here, this red waveform corresponds to individual chest compressions. This at the bottom refers to force. Down here is residual leaning on the chest, meaning as they release how much force or how much weight is still applied to the chest. And then this is the EKG rhythm at the top. My pointer up here, right here. These words refer to the pieces of feedback that are given out by the machine as CPR is in progress. So Bobby Sutton in the intensive care unit at CHOP has been kind of at the vanguard of this research. This was a study in pediatrics where he looked at children in our hospital that were getting CPR when the puck was in use, and we collected data both when the puck was on the chest and measuring quality, but with or without verbal feedback being given and incorporated. The left bars of each of these are what happens when feedback is being given by the machine. It's giving out the audio prompts, and the right bars are when it's simply used and no feedback is given. And you see that without feedback, meeting the appropriate parameters was pretty uncommon. It was about a third of the time. All right, and the last thing I'll talk about a little bit, and this is more of the work in progress part, is using video as a method of assessment. So the pros here obviously are that it is very accurate and unbiased. It gives the ability for a comprehensive assessment because the entire event in question can be viewed in its totality. The disadvantages are many. Obviously, it's expensive. It involves a lot of equipment that needs to be maintained, and it brings up issues of data storage and destruction and so on. And then, probably most worrisomely to some people, there are issues related to privacy, both for patients and for providers. And it generally is viewed as taking on some medical legal vulnerability by having these videos involved. And then the physical interference has been raised as one potential thing as far as being in the way of actual care provision. So a study last year from Ben Carey in Cincinnati was kind of a sobering one, looking at tracheal intubation in the pediatric ED. They've been video recording in their ED for several years now, and this is the output of a year's worth of data where they looked at intubations, and you see that they had 114 videos reviewed of kids undergoing RSI in their ED. Among the things they found were that the first attempt success rate across the board was only 52%. And when stratified by providers, you see on this graph that pediatric residents did very poorly. They were successful only about 1 out of 3 times. And maybe even more worrisome, the pediatric EM fellows, who are usually the go-to people for this procedure, were less than half, successful on their first attempt. The other things he found included that physiologic deterioration, hypoxia or bradycardia, was quite common. It occurred 38% of the time. Hypoxemia was present 1/3 of the time, and interestingly, there were 2 kids that actually had a cardiac arrest during their intubation. Both of them had prompt return of circulation when the intubation was performed. And the other thing he found that I think is very important is that the likelihood of one of these physiologic deteriorations occurring became statistically much more likely following attempt number 2. So if more than 2 attempts were necessary, there was a sharp uptick in the likelihood that there was going to be a physiologic deterioration during intubation. Is the other video there, Katie? There's another brief video clip that I can show you from, there's only about 10 seconds or so. There we go. So this is the video output from a study we did a little while ago. The data that we collected as background from our video intubation study. What we had done with one other aspect of this study was that you saw there that they were basically a trainee doing an intubation on a simulator using a video laryngoscope, a Karl Storz video laryngoscope, but not using the video to guide the intubation. So in other words, we pretty much just switched the video off and let them use it as a direct laryngoscope, which with the Karl Storz device is possible because the blades are standard blades. And we used the video from the laryngoscope as well as just video recording the mannequin and the intubator to try to document some technical aspects of intubation performance that you see on these graphs right here. And we just kind of generated a list of things that we thought were probably important to intubation success when it comes to technique, but that there's not a lot of data out there about the optimal, ways to do these things. And you see that they include things like bed height, the degree of mouth opening with the right hand, where the blade tip is placed, etc. And we were looking in this study to see whether we could make correlations between these technical aspects and success. And in brief, we couldn't. We didn't find anything. But we also noticed that a lot of this data is very, very skewed and not distributed particularly normally. And so we're not sure whether people were really intubating the way they would intubate a patient or not. But what we're hoping, at least we found that this using video to record these things seems reliable. And we're beginning to do this in real intubations in our ED, and hopefully we'll have some data to support that there are technical things that we can guide our trainees to do when they're intubating that will enhance success. And this is just a picture of the video output from Beeline live capture that we use in our ED, or at least in one bed slot in our ED, to record our resuscitations. We've been doing this as divisional quality assurance for a couple of years now, and we've begun to collect some data specifically on cardiac arrests. So this data is when we have patients that undergo CPR, we have research personnel that go back to the periods of chest compressions and physically assess. They basically count the compressions. You saw some of the data that I showed you from Bobby Sutton when he uses the devices to quantify this data. The trouble is that that device is only approved for children older than 8 years old, which for the ED kind of excludes most of the kids that we do CPR on, because most of our CPR is in infants. And, so there's a kind of a gap in terms of the feedback we can get from that device. So video allows us to get similar feedback simply by having someone look at the compressions being performed and counting them. And you see here that this is going to be presented in November at the Resuscitation Science Symposium. This is just a set of about 9 kids where we had a total of 186 30-second segments of chest compressions. And you see here that the target rate of 100 to 120 compressions per minute was only achieved about 28% of the time. But importantly, when you look at the other groups of data here, slow compressions were very uncommon. Fast compressions, in excess of 120 or 150 per minute, were quite common. And, I think no one knows what's too fast for CPR. It's intuitive that there must be a rate of compressions that is too fast, and no one knows where that is, but we see that the push fast part we seem to have down pretty well. But who knows? Maybe we're pushing too fast. Some of the other this is another interesting one. So ventilations, here we have about 144 segments of ventilations that we managed to capture. And again, this is one where the target range is the elusive 6 to 10 breaths per minute, which, as you see here, was rarely achieved. It was only 20% of the time. And instead, hyperventilation, sometimes even hyperventilation threefold above the recommendations, was quite common. And this is in keeping with what's been shown in other studies, both simulated and in real patients. Another interesting one for us in the ED is that, unlike ICU arrests, where most of them have artificial airways, in the ED, most of the time we have to coordinate compressions and ventilations. And that 15:2 ratio that PALS recommends was only achieved about 20% of the time during these segments that we reported in our ED. And then the sort of good news among the other parameters we look at is that compressor segments, by which I mean the time that one person spends doing CPR on the chest, was less than 2 minutes as recommended most of the time, 77% of the time. And then when you see down here the no flow fraction that we mentioned before, we aimed for less than 20%. We actually achieved that 100% of the time. The median no flow fraction in these kids was only 9%. All right, so that was all of the data and the review I was going to mention. And then briefly, just to tie this together, if you are faced with data like this and your needs assessment through whatever means, then what should the next steps consist of? And Katie, if you could animate this for me. So obviously, beginning with your needs assessments, that goes ahead to how you design your curriculum. You can just kind of click through, Katie. You don't have to wait for me. So implementation, followed by evaluation, followed by revision. And then the important thing to realize, I think, is that as you're implementing your needs and your curriculum design, deploying it and seeing the effect, is that the needs assessment probably shouldn't be a discrete phenomenon. It should be ongoing. It can even be a means of outcome assessment as well as needs assessments. All right, so then just to finish up, obviously the needs that you are assessing are going to vary based on who you are and where you work. There are multiple methods, and importantly, simulation can be a very effective means of needs assessments for known or unknown deficiencies or opportunities for improvements. And then the next steps following needs assessment are going to vary as well, but it should be kind of an ongoing, in a way, iterative process. And I think that was all I had for slides, so I'm happy to... Oh, I just want to acknowledge my fellows who did a great job of scripting their CPR performance and doing a, not so good job just for illustration purposes. That was not a real case, and they were scripted for me to, forget to do chest compressions for VF, which...